in clinical day-to-day scenarios, and this is going to be an inspiration to all of us. So we have a whole range of contestants here. I hope all the contestants have already come. We'll just start the... We have around 11 speakers here, and first I would like to welcome all the judges. We have our chairman here, but they would be probably joining us soon. Dr. Grover sir, co-chairman Dr. Gaurav Luthra. 1 minute, this is the... 1 minute, yeah, that was the prelim. Yes, 1 minute. Yes, I have that. Yes, thank you. Yeah, the chairman, Dr. Natarajan sir, he just called me. He'll be coming in just a minute. Our co-chairman, Dr. Chandriba Paul ma'am. Our convener, Dr. Chitra ma'am, she'll be joining us soon. And our judges, Dr. Prashant Bavankule, Dr. Naresh Babu, Dr. Virendra Agarwal, Dr. Kamaljeet Singh, Dr. R. Unikrishnan Nair, Dr. Purendra Bhasin, Dr. Nikhil Gokhale, Dr. Samar Basak, Dr. Jyoti Matalia, Dr. Bharati Kashyap, and Dr. Krishna Prasad. So we have our speakers here, Dr. Prasanna Venkatesh Ramesh. Yes, please come. He'd be starting the session today. We have 4 minutes of presentation and 2 minutes of discussion. The discussant, please be ready for the... Yes, please start.
Yeah. Good morning, everyone. I'm going to talk on my augmented reality innovation that recently we have done, called the IMG AR for teaching, diagnostics, as well as counseling with augmented reality. So I'm Dr. Prasanna Venkatesh, going to talk on my application. So this augmented reality application that we have innovated is in 4 dimensions. We wanted to use it real-time patient images which are high resolution for teaching, diagnostics, as well as for patient counseling and simulations. When you see an image in 2D, for me personally, I feel there is something more that we can add. So why not 3D, which gives me a high, and the 4D where we use hand trackers like the Iron Man Robert Downey that we can see. Ophthalmology being an imaging specialty, holograms are the future, which I tried to actually innovate and successfully did it. So I'm going to share this for the next few minutes as to how we use the holograms to create a 4-dimensional ophthalmic metaverse. The fundus and the OCT, if you see, it's quite self-limiting in that we don't really get one over the other. So what if we can have a fundus with the OCT intercept over it, and all dimensions of the eye from all the slices can be chosen, and we can actually treat the patient and also follow up him in such a way that you can choose any slices through means of holograms. So this is the hologram headset that we have created, and you can see that the user is actually walking through thin space, but when he uses this headset, all the images are in 4D. The eyeball models, the color fundus, autofluorescence, infrared, the brain structures, the cranial nerves, cerebrum, all those imaged are in 4D. And with the hand tracker, he can actually expand it, see the gonio structures, angle structures can be seen in gonioscopic view, Miyake-Apple view, the ciliary body structures, the electron microscopic view of the angles, and also the fundus images that we have done with confocal images. All these are real-time patient images which are unanimated that we see in a fundus can actually be examined and the diagnosis can be made. And this is a workflow. For a diabetic patient who comes into the hospital, a fundus and a OCT is done and it enters the hospital database. Our software intercepts it and it translates it under 60 seconds, it makes the hologram. And now a diabetic retinopathy with macular edema before treatment, you can choose the OCT slices from the same fundus plane, and we can see and also counsel the patient, not only a diagnostic tool, but also a counseling tool. So the patients can also be shown these headsets, these holographic headsets, and then be counseled as to in 4 dimensions what it is. So once we have placed the lasers and the anti-VEGF injections, again the same patient can be have a 4-dimensional counseling as to how things have settled down. So this will make them of our services also it's 4D diagnostics. So this is after treatment. Also, anterior segment structures like ASOCT, the retinal OCTs can also be studied. And for pre-surgical planning, this is a posterior polar cataract component that can also be planned before workup. So is this only for holographic headset? No. We have also given it in the smartphone as well. So all you need to do is install our application in the smartphone, and you can see the holograms in the smartphone as well. Any slices can be examined, and augmented reality eyeball along with cranial nerve system, cerebral venous system. The unique feature of our holograms are we use real images like the fundus, the anterior segment, the slit lamp, and we also published this concept recently in the IJO. To summarize this innovation, it's a patent protected technology that we have filed recently. It's useful in 4D diagnostics, 4D telemedicine, 4D AI. It's a multimodal imaging retinal examination device with color autofluorescence and infrared, low vision rehabilitation counseling, useful for neuroanatomy pedagogy, which are all complex three-dimensional structures that we are talking about, like the red nuclei, the cranial nerves, cerebral venous system. All these models have been created, and these are all real-time images that we have taken from the patient to reconstruct the 4-dimensional holograms. Thank you once again for the opportunity.
That was an excellent presentation, Dr. Prasanna. Dr. Prashant, what are your views on it? How practical is it? What would be the cost involved, and how can it penetrate deeper into the entire country?
Congratulations, a beautiful thing. Way of looking at it will be totally different, and in fact I think the way if you can incorporate more bigger digital multimodal imagings and all things, it will be really much more of a clinical use. Like you can see an actual lattice. Like now we have an UWFA, that is ultra wide field angio. You can show them a patient that this is your horseshoe tear. Well, you need a laser.
So now
it will be really good.
We are using Opto's fundus,
images.
and we have actually created that, sir.
That's
so
beautiful.
This hologram, it costs around 2 lakhs, but the one that we did in our smartphone, it is free of cost.
Okay.
Our idea is to create a module which is accessible to the mass population, and this is the QR code of the apps that we have created. Currently, it's in Android. It is totally free of cost that we wanted to give. This is quite costlier, which is around 2 lakhs INR.
Each piece.
Yes, sir. But this one is free of cost. So who are not able to afford this, with the QR code, it's free of cost in their Android phone, which is available.
So would they be appreciating it in a 4D structure or
Yes.
even on an Android phone?
Yes, sir. In Android also, it's in 4D.
Okay,
Not
great.
only a single slice, any slices is available in Android as well. But the
Absolutely.
features are better with the HoloLens.
Great.
Yes, sir.
Great innovation.
I'm very sorry for having joined in late because we were having our ARC meeting there, and I'm so glad to see all my very impressive judges sitting here, and I owe a lot of thanks to one and all of you for sparing your time to be with us, and we look forward to the first physical meeting, and I really look forward to making this Think Under the Apple Tree even more vibrant over the years to come, and we look forward to all your results and a very energetic ARC finals Think Under the Apple Tree happening today itself. And we would stick to the time of 4 minutes and with 2-minute discussions. And I want all the participants to collect their participation certificate from Mr. Shaktivel. I would like to introduce you all to him. Do collect your certificates after your talk or at the end of the session without fail. Thank you very much.
Thank you.
We would like to call upon the next speaker now, Dr. Karthikeyan Mahalingam, who will be speaking on U-Tool, a novel method of measuring corneal diameter in infants screened for congenital glaucoma.
I think we should have timer so that we understand.
Yes, there is a timer here which is seen.
Ma'am, that
Your-
was not
and that's-
working, so I just asked.
I want the audio visual team, I had told you all, the timer should be there.
Let it be visible, please.
Because it should be visible for the judges because they would score
Mark.
accordingly. I think the timer should be showing no on the screen also. No, not right now. Can you just wait for a minute so that we go properly?
And in front here also, please.
It should be an overlay.
Timer should be seen for the moderators and for the judges too.
यहाँ तो खाली हम लोग को दिखेगा.
चल नहीं.
And a very warm welcome, judges. I was not there when you all came.
Karthikeyan, in the meanwhile, you can start, please. अच्छा ठीक है कर लीजिए.
Come on this screen also. It should be 00 now. There. It is. Okay, you start from 0 so that we.
Ma'am, we can see here. Top, right up.
Yeah.
Top right, ma'am.
Yes, okay.
Good morning, everyone. I'm going to talk about U-tool, a novel method for measuring corneal diameter in infants screened for congenital glaucoma. How should I move it? Excuse me. It's not there. As is known, corneal enlargement is the common feature of congenital glaucoma. It is an important indicator for diagnosis and monitoring the progression of the disease. Castor caliper is being routinely used for measuring corneal diameter, but it needs examination and anesthesia or sedation. We devised a simple U-shaped tool using 3 shimmer strip or a printable ruler to measure the corneal diameter in settings where ophthalmic caliper is not available or UA is not feasible. And infants presenting to congenital glaucoma clinic, posters for UA were recruited. Before UA, corneal diameter were measured using U-tool. During UA, it was measured using Castor-Whicher caliper, and both the corneal diameters were compared. In cooperative children, U-tool was just placed above the orbital rim. If child is not cooperative, when the child was asleep, the eyelids were gently retracted by the attendant, and U-tool was placed. Then photo was taken with a smartphone. Care must be taken that the U-tool and the smartphone should be parallel to the eye so as to avoid the parallax error. Then see here you can see the smartphone and U-tool is parallel to right. Then using the image editing software, we draw a rectangular line extending through the limbus, and the readings in the U-tool is noted. Here you can see the readings are noted in various children. As we do not place the U-tool on the corneal limbus to measure the corneal diameter, a correction factor must be applied for the magnification caused due to distance. The distance from the corneal limbus to the U-tool was approximately 16 mm, and the correction factor at 16 mm distance was approximately 1.15 mm. The corneal diameter was calculated by multiplying the U-tool reading with the correction factor. Most of the patients were having primary congenital glaucoma. This shows that the corneal diameter measured with the Castor-Whicher caliper and U-tool were almost similar. By chance, if we didn't apply the correction factor, the diameter using the U-tool was 1.5 mm lesser compared to that of Castor-Whicher caliper diameter. The difference between the corneal diameter using two techniques was minus 0.1 mm with a narrow bland almond plot, 95% limits of agreement. It had a good correlation. Limitation include measurement error could occur if U-tool or phone is not placed parallel while taking the photographs. Sedatives or anesthesia might be needed in a non-cooperative children. 18% of the children required sedatives or anesthesia. Stretched limbus in congenital glaucoma could also cause variation in measurement of corneal diameter by different observers. To conclude, this is a novel innovation, provides a no-touch technique of measuring the corneal diameter. Considering a difference of plus or minus 0.5 mm within the acceptable range, 72% of the readings taken with a U-tool were in acceptable range. It provides a corneal diameter measurements in awake or sleeping state with or without use of sedatives or anesthesia in majority of the cases. Hence, it can be used for screening pediatric glaucoma by first contact physician, optometrist, or by ophthalmologist, especially when the UA is delayed. Thank you. Thanks. Thanks.
Thank you, Karthikeyan. I'd like to have the esteemed opinion of Dr. Samar Basak, sir.
Thank you, Karthikeyan. This is wonderful, simple, and very effective for pediatric, age group to measure the corneal diameter. So we usually do sedation or this thing, but this is wonderful and your correlation is good. So I think there is nothing, it is so simple.
Thank you, sir. Thank you.
Thank you, sir. I'd like to request Dr. Samar Basak sir to please give a. Karthikeyan, can you come here itself? वहीं पर हो जाएगा सर, वहीं पर हो जाएगा. हाँ. एक मिनट इधर से आके फोटो ले लीजिए.
Thank you, sir. Can we have the third presenter, Dr. Santosh Bhide? He would be speaking to us on a novel chopper for stress-free chopping.
Shall I start?
Yes, please.
Respected chairpersons and friends, good morning. After two brilliant talks, I am going to talk day-to-day. The topic will be useful for day-to-day practice, and that is novel lateral chopper. आगे क्यों नहीं जा रहे हैं?
इनका slide move नहीं कर रहा है.
Can somebody help him from the AV team?
They're doing that. They're in the corner.
Okay.
ठीक है.
Sorry,
Thank you.
Sorry. Chopping is the most important step in phacoemulsification, and we all know that it was introduced way back in 1993 by Nagahara. And since then, there are many modifications in the chopping technique. We all know the principles of chopping as well as science behind chopping. There are various choppers which are available in the market, but basically they are of two types, mainly horizontal chopper and a vertical chopper. Horizontal chopper has a sharp inferior edge, while a vertical chopper has a sharp tip. So while doing phacoemulsification, there is a chance of accidental rupture of the rim of the anterior capsule, especially when the newcomer is doing a phaco or a student is doing a phaco surgery. Hence, I thought of designing a novel lateral chopper which will be safe for a newcomer. It has a blunt tip, so there is no chance of damage to the rim of the anterior capsule or the posterior capsule while doing phacoemulsification. The under surface is smooth and sharp edge is facing phaco probe. It is on the lateral surface, so it helps in cutting the hardest of the nucleus. The tip is also less bulky, so that there is less leaking from the wound and better chamber stability. And this chopper is used by a right-handed surgeon, so the sharp edge is on the right side. When the surgeon holds this chopper in his left hand, the sharp edge faces the phaco probe, and then it is quite easy to do the chopping. For the left-handed surgeon, the sharp edge will be exactly diagonally opposite. So now let us see the use of chopper. This is a grade 4 cataract, dark brown, leathery cataract. And look, because of the sharp edge which is facing the phaco probe, the cataract can be cut quite easily into multiple pieces. And because of the ease of cutting of the cataract, there is less requirement of the phaco energy. This is a grade 2 plus cataract. After holding the nucleus, the chopper just slices through the nucleus like a knife going through the butter, and hence there is a very less phaco power utilized during surgery, thereby the endothelium is protected. Look at the movement of the sharp edge, which is away from the edge of the capsular axis rim. So there is no chance of damaging the rim or the posterior capsule. So to summarize, this new chopper has advantages because of blunt tip. There is a less chance of damage to the rim of the capsular axis. Sharp edge is on the lateral surface, which works in plane parallel to the rim of the anterior capsule. Hence, there is less chance of accidental damage to the edge of the capsular axis. The tip is less bulky, so there is less leaking from the side port with better chamber stability and ease of surgery. And all in all, it is a user-friendly device. I would like to thank Chairman ARC and Team ARC for giving me opportunity. Thank you.
It was an excellent presentation, Dr. Santosh. Dr. Virendra Agarwal, would you please give your special comments on how you feel about this?
It was a novel idea, and it's a good idea because everybody who is here must be doing cataracts. Very few are not doing cataract, and we do get patients who are in hard cataracts or difficult situations. So everybody needs some different chopper for different cases, and it's a good idea to have the sharpness not on the tip, because sometimes I prefer to do a vertical chop. It is a problem. but definitely it is not for all patients. So
Yes.
I think everybody will require some modification, but overall it's a good idea.
Yes, thank you, sir.
Is there any difficulty when introducing the chopper through the side port, because if it has a lateral sharp edge, so
There is no
that you need to be
difficulty. That's why the size is not big.
Yeah.
Or because of sharpness also there is no difficulty in introduction, or
not
it doesn't.
difficulty means it could get
In
just
fact, it is
extended
very
in a
easy. It doesn't get extended.
It is not that sharp.
It
like
is
a
not
blade.
that sharp.
Yeah.
In
It's
fact,
not.
some
It
of the
look
choppers
wise
have
it's not
bigger
that
and
sharp.
sharper tips. So if a newcomer is introducing again and again,
So
then there is
the-
a chance of
the
increasing.
sharpness, the sharp edge lasts for how long of the
Sharp edge is for 2 millimeters from the tip. It's only 2 millimeters from the tip.
And with the sharp tip, sometimes you get epithelial problems also while
Yes,
entering.
yes.
So blunt tip is definitely a novel idea.
And even if there is a flutter, there is no chance of damaging the posterior capsule during surgery.
Yeah. Good idea.
Thank you, sir.
That's nice. Can we have Dr. Agarwal to please?
My pleasure.
Dr. Maurya has asked he will be late.
Will it? Yeah, I was about to say that. Okay, then can we have the fifth speaker, Dr. Narendra Singh Verma? He would be speaking to us on toric marking topographer.
Thank you. This is video presentation. Thank you AIOC for this opportunity. In toric lens implantation, today's potential source of error is due to domino effects caused by a multitude of factors which lead to considerable post-operative refractory surprises. I am here to present an efficient solution to this problem, the toric marking topographer. This system prevents errors during measurement of axis of astigmatism, marking of axis of alignment, and positioning of toric lens. The system is a spot reflection based topographer. The illuminating disc is octagon shaped, having 600 color LEDs. Camera is in the center linked to an image processor. Display system including phones, tablet, laptops, etc. can be connected wirelessly using Wi-Fi. A toric marking app is incorporated in this system.
Efficiency of this system is better than the existing solution as it saves time and cost. Simultaneously, it provides high quality of result by eliminating errors.
Examination of a patient is completed in 3 easy steps. Capture a topography picture, manual keratometry, immersion A-scan. Toric IOL workflow with toric marking topographer. 60-year-old female having right eye nuclear cataract grade 2. Left eye pseudophakia operated 2 months before. Monofocal lens was implanted and residual refractive error is 2 diopter cylinder. Without use of any eye drops, we can capture a topography picture of the eye. By measuring the diagonal distance between these points, the system measures axis of astigmatism, which is 168 degrees in this case. Unlike other solutions, in this system there is no absolute need to keep the head perfectly straight. Manual keratometry to measure K1 and K2. Immersion A-scan to measure axial length, anterior chamber depth and lens thickness. The above data is used in Barrett's toric calculator to calculate recommended IOL power and axis, which is 174 degrees in this case. So, implantation of 25 diopter lens with 2 diopter cylinder in 174 degrees was planned. Now, in this image guiding app, enter the recommended axis of alignment, which is 174 degrees, and site of incision, which is 150 degrees. On this topography picture, the app will mark axis of alignment as a green line at 174 degrees with red lines on either side 5 degrees apart. Site of incision is shown as a pink square at 150 degrees. There is also an option to place yellow lines along the axis of landmark points. It is 32 degrees in this case. This is the final picture used for reference during the surgery. The picture is rotated such that it coincides with the microscope view of the operating eye. You can save it on your phone, tablet, pen drive, etc. and use it during axis alignment of toric lens. Mark the landmark point, which is at 32 degrees. After in the bag implantation of lens and thorough viscoelastic removal, the lens is rotated in axis of alignment by coinciding the limbal structures with lens markings on either side. There is a difference of 38 degrees between landmark point and axis of alignment. So for final confirmation, hold Mendez ring such that its 38 degree marking coincides with the landmark point. In this position, the lens markings must face 0 and 180 degrees. Post-op 3 weeks. Right eye in which toric lens was implanted using toric marking topographer, the residual refractive error is half diopter cylinder. And in the left eye in which monofocal lens was implanted, the residual refractive error is 2 diopter cylinder. Here is another patient as an example. Capture topography picture. The system will measure axis of astigmatism, which is 155 degrees in this case. Manual keratometry. Immersion A scan. Barrett toric calculator is used to calculate recommended axis of alignment of toric lens, which is 160 degrees. Use the toric marking app to mark axis of alignment and site of incision on the topography picture. After final alignment, P1 and P4 Perkin-J images are coincided to eliminate parallax error.
Thank you. After doing thousands of foldable lens in the bag, I was not having confidence to do the toric lens, because what will happen second day, kal kya hoga, that was the main problem. And the fear of the misalignment and rotation of the lens is very much for the surgeon. So this is very small. The principle is very simple, that only we have to take the one topography picture and mark the axis of alignment on this and use it that on the operation theater. So this is my presentation.
Excellent presentation. Dr. Nair, would you like to comment on it?
That's a wonderful presentation, a very cool way of doing things. I just want to ask one question. Intraoperatively, how do you map the image while doing surgery exactly on the eye? That is, the image comes and you don't see the cornea at that point of time. And point number two, how easy would this be for a new person, and what is the learning curve for a new person to suddenly come on and do this?
Yeah. So we are having the photograph. We can keep the photograph in the tablet, rotate it. When we are setting the site of incision, and you can keep the site of incision the same time in the tablet. You are knowing that there we have to put the lens in 174 degrees. So you will go up to 170, 160. Then you will see on the left side which are the limbal structures, and the right side are the limbal structure. Then you will rotate it, and you can check it by Mendy's ring, because in every eye there are some landmark points. So you know that how much is the distance of the landmark point from the axis of alignment. So you can mark two landmark point, use the Mendy's ring, and then you will put the ring. Then you can see that both marks of the toric lens, they should be at 0 and 180 degree. So it's very easy. And in the app we have to just enter only two things: recommended axis of alignment and a site of incision.
Before the co-registration with all these devices, people used to use pictures and hold it in the direction. How does this differ from that?
This is, and the main thing is that we are using, what happened, they are taking the topography picture. During the time of topography, head may tilt, and then they are marking. So then marking, then head may also tilt. So this is independent to the head position.
How is it independent?
So I am taking the photograph. Look, consider my recommended axis of astigmatism is 90 degree. If at the time of examination, if I will move like this, it will go to 85 degree. The photograph, in the photograph, I will move in any side, but we are measuring on the photograph, axis of alignment. And axis of astigmatism, we are measuring on the photograph, and that's why if the photo will move, axis of astigmatism will move. So in any position you can, so that was also a big problem for me. For examination, I have to say the patient, कि सीधा रखो सिर, इधर थोड़ा भी नहीं tilt होना है. I was moving my system from this to this side, that they are on the same level. So that was a big problem. So in this, there is no need to, only one photograph which mark the axis of alignment, same photograph mark the recommended axis of alignment, because it is slightly 5 to 10 degree away from that steep axis of astigmatism. So there are chances of that some सब है miss किसी ने गलती से कुछ अगर कुछ एक्सेस वगैरह चेंज कर दी, वो भी नहीं होगा.
Okay, sir. I think we can discuss again in the finals. Thank you so much. Can I please ask you to present? Meanwhile, yes, ma'am. I agree. Right. Live presentation, absolutely. Yeah. In the meantime, Dr. Ashish, can you please start your presentation? Dr. Maurya, I think, is here. After this, please be ready. Yeah. So, Dr. Ashish will be presenting on post-vitrectomy recovery systems.
A very good morning to everyone, and thank you AIOS for giving me this opportunity. I'll be presenting on the topic of post-vitrectomy recovery system. So it's a support furniture to help patients maintain face down position after the retina surgery. So the problem statement is, So vitrectomy surgery has evolved dramatically over the past 50 years. Since the time Robert Macimer introduced it in the year 1972, we live in a country with a population of 1.3 billion people, and going by the studies, we have an average incidence of about 1.3 lakh cases of detachments happening every year. So this is to give a rough idea. So the problem we are trying to solve is that vitrectomy surgeries usually require in certain cases for patients to maintain face down position for a period of 10 to 12 hours after the surgery, and the duration varies from 4 days to about 2 weeks period. So the prone positioning is needed for the tamponade agent, either the silicone oil or gas, to support the retina. But the real world scenario is that it is very difficult for the patients to maintain face down position, which is due to variable reasons like a back problem or the uncomfortable posture giving rise to chest pain or causing breathlessness. And when I looked back, there was no real way to track the duration for which the patients were maintaining prone position in spite of the doctor's advising, and the failure to maintain the position in certain cases can affect the surgical outcome. So the PVRS system, my colleague Harsh will just demonstrate. So it consists of a tripod-shaped furniture with a horseshoe-shaped cushion, the headrest, in which we have a sensor incorporated in the center at the heart of the horseshoe-shaped cushion. So it's a pressure sensor. When the patient places its head on the cushion, the data will be relayed via SIM card incorporated in the sensor, and the data is relayed to our website. We have applied for a patent for the same, and we have a trademark and design registration done. So this is version 2, and we have developed a backend and the website as well. So this is how the dashboard will be seen with the patient name, and we have a very easy to see and interpret bar diagram which will show the data on daily basis as to the duration for which patient is maintaining prone position. This is a short live video of our website taking you through the website details. So how the data is relayed is in a small pockets of data which will be displayed in just a few seconds. So this is how the data is relayed. There is a date timestamp. So every time the patient is maintaining a face down position for 10 seconds, 20 seconds and lifting it up, so the data will keep getting relayed to the server online. So we can keep a track and have a cumulative data at the end of the day. So we had done a small pilot study to investigate the validation of this device for patients after a vitrectomy surgery. So we had recruited patients who had undergone macular hole detachments and one patient with open globe injury. So what we found was overall the adherence was significantly better to maintain face down position, and patients showed a good compliance to maintain prone position by using the device. So what lies ahead for us is a bigger validation study is underway, and we are constantly working on more different devices for patients to maintain prone position, so this currently patients can use in the sitting position, and the headrest is detachable, so patients can take it and lie down on the bed. This has to be connected via power bank, which will supply the electronic circuit in the sensor. So it's very easy to use, and thank you.
That was an excellent presentation. Dr. Purendra Bhasin, sir, your comments, please.
Dr. Ahuja, I should appreciate the way you have developed this thing, and this is really a good thing. But one thing is there any study which tells us about how much time the patient has been in the prone position and the outcome of the anatomical outcome of the retinal reattachment? I don't think there is any such study which has been done till now. So that is what it is. How useful it is going to be.
That is very debatable, sir. You're right. There are studies for it, against it. But, clinical experience of senior surgeons, our teachers and mentors, what we practice is we do advise patients. Yeah. As a surgeon, we'll try our best to, achieve that anatomical success. Even if this gives an edge of 5 to 10%, if it increases the chances of success, we'll take it. And there is no harm or downside.
No, there is no harm as such, I tell you. But my suggestion is to have something some device wherein patient can be comfortable and he can read also, maybe he can eat while in this position. If you can develop in that way also, that will be nice. But otherwise, it's good.
Is the height adjustable for this?
Yes, ma'am.
Yeah, okay.
It has,
Ashish, I have a suggestion. Keep a iPad there so that if the patient's mind is engaged, he doesn't feel the neck strain. iPad here.
Yes, sir.
That can be something, some device like.
Yeah.
Ashish, this is pressure based. There is a pressure sensor. What a patient like me keeps a pillow and walks away?
Sir, we have a weight. The sensor is sensitive to at least 1.5 kg of weight. At least, I think, above 1 kg of weight is needed for the sensor.
Okay,
We
don't reveal
calibrate.
that, then we'll keep a brick and we'll go.
Yes, sir, that will happen.
He may be keeping head down but not pressing it. That is the issue.
Yes, sir, there are limitations.
Yeah. Thank you so much. Dr. Ash.
Obvious question, cost for the patient. Cost of the device for the patient, including the tripod.
Cost.
She's asking about the cost.
The tripod, battery pack and the pillow sensor, what will be the end cost for the patient at present?
So, see, currently it is more of a rental model. Because patients don't need it after the...
So what's our build cost?
Around 4,000 rupees.
Build cost.
Okay.
But most patients, we have started providing this in...
Are you ready?
In Delhi, few doctors in Ahmedabad have used. So most patients just want the furniture or the cushion. So, it comes to the cost in the real world scenario.
Okay.
So the technology is there.
Excellent. Yeah. Dr. Arvind Kumar Moria would be the next speaker. He would be speaking to us on smartphone annotation tool for image labeling for artificial intelligence and diabetic retinopathy. Actually motivating and helping people to come out with their ideas, and actually all these ideas can in due course of time be so much more practical for all our patients in our clinical scenarios. So it's very important to appreciate all these efforts also in all our day-to-day clinical scenarios. All of us are so busy in our day-to-day practice that many times we may not take the effort of doing all this. So I really congratulate each and every one of these speakers who have taken time and effort to come out with such nice ideas. So can we have the slides, please?
So good afternoon, everyone. Successful application of regenerative medicine solution for corneal ectasia. This is my topic. So this is the problem that in ectatic corneas, it becomes progressively thin and also curved. So the current solutions include contact lenses, collagen cross-linking, or in the advanced stages, corneal transplantation. So regenerative solution, if we think about the concepts that regenerative solutions have, then at one end of the spectrum, what we have is organ decellularization, which is done ex vivo. Native cells are then introduced into the ex vivo organ, and then finally we seed it and maintain it in a bioincubator. At the other end, we have wherein in vivo we introduce either ex vivo expansion of cells or recruit cells from the patient's own distant organs like the bone marrow. So we hypothesized, we started with a hypothesis that it is possible to thicken the donor cornea or to an ectatic cornea or a thin cornea by using a decellularized matrix hydrogel, which we can either make from a human source or some other source. And with time, as it integrates into the donor tissue, it becomes transparent using cues from the microenvironment that it is exposed to. So now for testing this, we initially created an animal model in the rabbits. Can you please escape from this, AV team? So for making this animal model, we created a stromal depletion in the rabbit cornea under anesthesia by doing lamellar dissection. The flap was then replaced and then the dead space was left as it is, and the animal was harvested at the end of 5 months. At the same time, we also developed a hydrogel This hydrogel was made either from the human cornea or from bovine cornea sources. The corneas were minced, decellularized using enzymes, and they underwent lyophilization, digestion, and then created into a pre-gel format. Now this pre-gel was unstable in the pH, and therefore it was used by sodium hydroxide. It was stabilized. So what we showed was the DNA content considerably reduced from 100 to less than 3%. The other contents, that is which contribute to the extracellular matrix, that is the glycosaminoglycans and the collagen content, didn't reduce very drastically, which is what we wanted. This gel was then injected into the animal model that we created, and at the end of the 5 months, the animal was sacrificed and the corneas were analyzed. So we have successfully shown that the matrix actually integrates into the cornea, and most of the cornea, if you can see, has maintained its clarity. One animal had an infection and therefore had this scarring at that area. So we showed that the hydrogel actually integrated, and also there was some migration of the resident cells. Now we also showed that the ectasia model was successful, wherein at the end of 150 days there was thinning in the cornea. This was also showed by CT-FIR mode images, wherein the depletion model that we created had the lamellar arrangement similar to that seen in keratoconus or other corneal ectasias. Now before I come to the advantages and drawbacks, I'd like to say that what we aim to do in regenerative medicine is to resurrect the normal anatomy and physiology of a dysfunctional tissue at a cellular and subcellular level. So we can either control tissue morphogenesis, deliver crucial signals to the resident cells, and or deliver crucial signals by using infiltrating multipotent cells. So what we have targeted is using the resident tissue specific progenitor cells. Now the advantage is that this is the first model that has demonstrated a thinning for over 5 months. Secondly, we have used hydrogels which are probably going to be much better accepted in clinics than any implant or any other stem cell source. So also time and cost effectiveness, and we have also demonstrated migration of the functional cells. So we intend to go for different sources of hydrogels, also recruit mesenchymal stem cells, and repeat the animals in a larger set of animals.
Yeah.
Thank you very much for your patient listening.
Just a quick comment, because we're already short of time.
That maybe we should also look at the stiffness after you have augmented the corneas with hydrogel, because that is the final test of.
Please be ready with
since it was in vivo in the rabbits, and the rabbit cornea maintained its structure, but yes, we can measure. That's a good suggestion. Thank you.
Yes. Thank you so much. Please collect your certificate from Dr. Nikhil Gokhale. Can we have the next presentation ready, please? Dr. Maurya. Yeah. So, Dr. Maurya will be presenting on smartphone annotation tool. We didn't have the timer for her presentation. Can you please put the timer back? And the next presenter, Dr. Divya, also please be ready with your presentation.
Hello everyone, good morning. Thank you ARC for the opportunity. Myself Arvind, and I will be presenting my invention on a smartphone annotation tool for image labeling for artificial intelligence in diabetic retinopathy. We initially began by asking doctors to annotate the images using online platform, but faced some of the following issues, like volume of the data increased over time and less portability because of desktop sites, long images loading time due to weak internet connections, ever-changing disease schema, and as we kept on receiving some new data from hospitals, we could not upload to these tools as it may violate patients' data privacy laws. This led us to develop our own in-house image annotation tool as seen in the video. Adding in annotations for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images. The graph also shows the maximum number of images stacked by the other users in real time and gave the daily target settings. These imaging data sets are generally in the range of thousands and can be overwhelming for a single person. So we chunk them into sets, each containing 1,000 images or less, which a grader can complete in 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resize images into smaller size thumbnails with a smaller memory footprint and still maintaining the visual quality. We leveraged the asynchronous capabilities of the browser and didn't load just one, but 3 images preemptively so that the creator doesn't need to wait for the next image to load. The initial interface was basic and it is stopped. Yeah. The initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested subclassification and extra options. Finally, on the developer's end, we managed to Dockerize the entire application and deploy it using the Kubernetes platform. So we have seen a total behavioral change where on the online tools, the grader used to work only on the weekend, but on our tool, we have logged users on all days of the week. Average time taken to label a single image reduced substantially. We validated the AI algorithm, developed using annotations on this tool on some new testing data sets and found them to have a really high performance score. This again strengthens our hypothesis that this tool is no different than the desktop-based tools and with added advantages of being portable and flexible. So on the basis of satisfactory levels of verification and validations, we are developing a smartphone-based app on a binary system of referable or non-referable decision for the common retinal disease. On this unique convolutional neural network-based algorithm on feeding a single retinal image, it undergoes multi-level screening to provide a diagnosis in less than a minute to decide whether referral is required or not. Also, there is a color coding to decide between a normal light green cold zone and an abnormal red hot zone, along with a specific measurement of various biomarkers like in glaucoma for referral. Hopefully very soon it will be available on Google Play Store. We wish to introduce more gamification, label optimization to be used in telemedicine with some minor tweaks. This tool can be easily adapted to work for other domains as well, such as anterior segment telemedicine, radiology, dermatology, etc. Thank you so very much.
Nice presentation. Dr. Nair, your comments, please.
Yeah, that was really nice. It's using the most important tool in our century, the smartphone. One question, how do you maintain anonymization of data? That it comes, it is graded, and it is reunited with the patient data. How is it done on the instrument?
Previously, we used the publicly available data. Right. And now we are using the data after taking the proper consent.
No, but how do you separate the patient labels, grade it, and reunite it with the patient labels on the smartphone?
I'm not, if any image is feeded, right?
No, but you have a patient data. You have to remove the patient data before it goes for grading. Yeah. And after grading, it has to be reunited with the patient data.
Yeah.
How is that done?
On cloud?
So your patient data is not secure on cloud?
Definitely means we are taking consent from the patient that it will be used.
Okay, yeah. I mean, that's fine. Second point is that how is the inter-observer variation if you use two quality of cell phones here?
Yeah.
A very high-end cell phone and a very ordinary cell phone. Have you noticed any difference in inter-observer variation?
No, because we have this contrast and brightness, so we can make any image. 5% of the images, they can't be graded, right? Otherwise, we have contrast and the brightness slider, so we can grade any image.
Sure. Okay.
Yeah. Thank you. Thank you.
Please collect your certificate from Dr. Nayan. Okay. Regarding the rest of the speakers, Dr. Divya, Dr. Vivek Arvind, Dr. Ujjwal Rathi, Dr. Prabhu Bhaskaran. Anybody present here? Yes. Please come. Dr. Vivek Arvind, Prabhu. Okay. Yourself? Okay. Then Dr. Vivek Arvind is next in line. Please be ready. Dr. Divya is absent, I believe. Yes. Dr. Ujjwal is absent. Dr. Prabhu, you will be next.
Okay.
No. In the line, Dr. Vivek Arvind is first. Who is Dr. Vivek? Yeah, please come. Is your presentation ready? You have the list, no? According to that only. Dr. Ujjwal Rathi and Dr. Divya, they are not present here. Okay. Yeah, please start.
Good morning. I am Vivek Arvind. My topic for today is efficacy of intradermal voriconazole injection as an adjunct in non-responding fungal keratitis. fungal keratitis is a serious cause of blindness worldwide. It accounts for 30 to 40% of the keratitis in some part of the world. In India, it's more than 50%, and it's more common in tropical and subtropical areas. Treating fungal keratitis is a challenge for ophthalmologists as the penetration of antifungal drugs are inadequate. Voriconazole is a triazole antifungal agent and is a has a broad spectrum of action. The economical and efficient strategy of using voriconazole is through intrastromal route. In our study, we have reported the use of intrastromal voriconazole in 84 patients who are not responding to topical and systemic antifungal drugs. The aim of our study was to study the efficacy of intrastromal voriconazole injection as an adjunct in non-responding fungal keratitis. The objective was to compare the pre and post treatment size, depth, and infiltrates best corrected visual acuity over a follow-up period of 1 month, and to observe if for any complications, and to study for the association of risk factors like topical steroids and uncontrolled diabetes. It was a hospital-based interventional clinical study. The clinical data collection were undertaken following an ethical and written informed consent. All patients underwent a detailed examination. The study duration was 18 months. All patients with fungal keratitis proven by the presence of fungal filaments on smear or culture and not responding to topical natamycin and oral itraconazole for 2 weeks were included. The patient with adjacent scleral involvement, impending or frank corneal perforations, presence of desmetocele, endophthalmitis, etc. were excluded. Then the method of intrastromal injection preparation, 2 milligram of dry lyophilized powder will be reconstituted with 4 ml ringer lactate solution to form a concentration of 500 micrograms per ml. The reconstituted solution will be loaded in a 1 ml tuberculin syringe with a 30 gauge needle. Under topical anesthesia or peribulbar anesthesia, the preloaded voriconazole will be injected into the cornea under operating microscope, and the needle will be entered from a clear zone till the margin of the infiltrate at mid-stromal level, and the medication will be given at 3 to 5 divided dose around the infiltrate. Then coming to observation and result, higher number of cases were seen between the age of 46 and 60. And most of the patients were from rural areas, and 50% of the patients had an agricultural background, and most of the patients had a history of injury, and the most offending agent for the trauma is vegetative matter. Then 13% of the patients had uncontrolled diabetes, 6% had topical steroid usage, and 4% had dacrocystitis. The time of presentation was 16 to 20 days of onset in most of the cases. Then scar formation was started in 47 patients by 7 days, and 54 patients got improved in 21 days, and 22 patients had to undergo intervention like therapeutic penetrating keratoplasty. Then best corrected visual acuity also improved in 50% of cases after injection. Then coming to discussion, our study had higher number of sample size when compared to similar studies, and 73% of the patient got improved in our study. Then in conclusion, it can be used as an adjunct. Epithelial defect size and stromal infiltrate size has a correlation with the efficacy, and it is also cost effective, and intrastromal injection of voriconazole is safe. We in our study we didn't come across any complications. The limitation of our studies, we did not take any control group in our study, and the follow-up period was only of 1 month, and the causative organism might be having an impact on final outcome. Thank you.
Thank you so much. It was a nice presentation. Dr. Jyoti, your comments, please.
No, actually, ma'am, the positive side of our studies, we have a larger number of sample size. Most of the studies had only 20 around sample size. So, ideally, what would have happened? You could have compared with different types of fungi and seen whether it really works. Yes, ma'am. That's our. So your would have got more weightage to what you're doing, because what you mentioned is already reported. I understand number of cases, but doing something different would have helped in giving us. Yes, ma'am. Thank you.
Nice. Please collect your certificate from Dr. Jyoti. Dr. Prabhu, please be ready with your presentation. Ujjwal is not there. Dr. Ujjwal and Dr. Divya are absent. Yes. So Dr. Prabhu Bhaskaran would be speaking on a novel suture thread device for easy scleral fixation of a multiprice intraocular lens.
Good morning, one and all. Can I have the presentation? So whenever we think about esophageal surgeries, these are the names that would pop up in our minds. To the left, Gebhard Shariat, he was the original innovator of esophageal surgeries. The technique has a steep learning curve because of the zero working distance that he has, conceptualized. Because the point of sclerotomy and the starting point of scleral groove is almost the same. So it's probably, it's difficult to tuck in. So Amar Agarwal simplified the technique by keeping the working distance, little more. He kept the scleral glue slightly away so that it becomes simple, but you need expensive glue for that, and also scleral flap. The more popular technique in the recent past, flange technique by Emane, it's popular, but the concern is there is inadequate intrascleral aptic length. Sometimes it looks like 2-point fixation. So this is when we thought, can we not have a simple, cost-effective, at the same time, a technique that would achieve adequate intrascleral aptic fixation. That's when we came up with this concept of S-fix, or suture-guided aptic fixation technique. Basically, this is a technique device. It has 3 components. One is a polyamide tube, which is attached to the 50 nylon suture, which is crimped to 380 micron customized spatulated suture. This is an animation video where you can see the hollow cannulated polyamide tube, which is attached to the 50 nylon suture, and to the other end it's crimped to the 380 micron customized spatulated needle. These are the surgical steps. First step is docking. You dock the aptic, exteriorized aptic into the polyamide tube. You push it inside. That's the second step. You push it till the polyamide tube goes inside, intraocular. Then you take a suture bite. That's the third step. So the starting point should be very close to the point of sclerotomy. You take a bite around 3 mm and then you exit and gently pull it. As you pull the suture, you can see that the aptic would simply follow the suture track that's been created by the 380 micron suture needle. So once the aptic comes inside, you disengage that, repeat the steps on the other side. The IOL is fixed. Let me show a surgical video. You can see the docking step. That's the first step. Once you dock it till it reaches the suture-filled portion, that's about 4 mm here. And the second step, you push it inside till the polyamide tube. The yellow portion goes completely intraocular. No worries, it will not slip inside because there is a fit is good. And the third step is taking a suture bite from the point of sclerotomy. Around 2 to 3 mm we can do. This can go transconjunctival. Probably if there is a little bit of conjunctival chemosis, you can always do a peritomy and do it directly on the sclera. So once the scleral bite is taken, you got to pull it. So keep pulling gently. So this is the third step, keep pulling. So you can see that the aptic is going to just follow the suture track that's being created. So we have made this nylon polyamide tube junction pretty strong. We have given a gluing length of 4 mm. So that takes the entire resistance involved in the process. The aptic will not face any resistance. It will simply follow that. You can see a little bit of aptic outside. That's absolutely not an issue. You can always push it back with the McPherson forceps. That in fact gives scope for titration. You can actually adjust the IOL at the end. So do it on the other side. So push it completely inside till the aptic touches the suture-filled portion. You can see there are 2 portions of the polyamide tube. One is suture-free, which is the hollow portion. Now you can see the second step. I'm pushing it inside. Push it inside till the entire yellow portion, that's a polyamide tube, should go inside. Yeah. Then the third step is suture bite. You take a bite of 3 mm. So once that is done, you can keep pulling the suture. It's going to follow. So also you can see that the polyamide tube is a straight or cannulated one, whereas the aptic is curved. So once you dock, the fit is going to be pretty good. So it's not going to really give way inside the eye. As I said, the tube polyamide junction is very crucial. We have provided adequate strength. We have tested in various scenarios, and we have came up with this idea of 4 mm gluing length and 4 mm hollow cannulated portion. So you can see the IOL is well centered. So thank you.
Thank you, Dr. Prabhu. Dr. Prashant, would you like to comment on this?
Prabhu, would there be a part of the suture which is extrascleral? Part of the haptic which is extrascleral subconjunctival? It comes out.
I understand.
Yeah,
so the idea is if you take this, scleral bite pretty close to the sclerotomy, then it should not happen. Even if there is minimal, if you tease that sclera over there, it really, gets under that. You can actually bury it. So the idea is to keep the bite pretty close to the sclerotomy points.
The only thing is if we create a flap and get that haptic out through the flap, so that throughout it will be intrascleral.
Yes, sir.
That would be a food for thought. But otherwise, it's a very nice innovation. Great, congratulations.
It's a wonderful thing that the suture with the tube, that is something very unique. But I think that is the only catch here, that the suture bite should be very close to the place from where you have entered the cannula inside.
Yes, sir. Otherwise, we can open up the conjunctive. And then do it. Yeah.
Prabhu, I have got one question. Yes, sir. So you are pushing the tube into the vitreous cavity, and then you are taking the suture and pulling. See, we have got good forceps. Why can't you just push the haptic into the groove? Why you need that extra step?
So that's what sometimes working distance becomes little difficult when when the working distance is very minimal. You're taking the tip very close to the sclerotomy point and pushing it. Sometimes the forceps misses it. The haptic slips inside intraocular. That becomes a challenge sometimes. This is an alternative option. You can always have it in the armamentariums.
Just the tip of the haptic, if the intrascleral groove is not long enough, the tip of the haptic may also be outside, not at the entry point. The other side could be outside also.
Yes. So the options are one, we can, if you feel it's, you can always push it inside, you can titrate it. If it's still excess, you may trim it also, not an issue, or you may flange it and keep it inside. But I prefer to push it inside and titrate the IOLs.
Have you compared it with the other techniques and seen the stability and rotational stability of the lens?
We are in the process, madam. We are in the process.
Yeah, thank you so much. Can you please take the certificate from Dr. Natarajan, sir? Here. No. Dr. Divya and Dr. Ujjwal Rathi are absent. Yes. Any comments from any of the judges?
I think Natarajan
sir,
can.
Yeah, that's what. Dr. Natarajan, sir, your comments on the entire thinking under the apple tree, the concept, and you have been an inspiration to all of us.
He wants to record, I come late.
So I have a...
Anyway, I apology for that.
Ek minute.
So your comment.
No,
I have a question to Charuta. Actually, this term is sacrifice the animal, like any animal study, is now very difficult to do animal study. So Charuta can answer.
Charuta,
because this terminology, you are doing some work with, mostly with rabbit, then you sacrifice that animal to take out. There are a lot of issues now. Because we are trying to collaborate with other and we fail to convince the local, whosoever given permission. But I think your lab is taking all
we collaborated with Jiva Life Sciences, which is a contract research organization, and we presented it to their ethics committee. But the previous study had also done it on rabbits, the collagenase model of stromal depletion. But they did it only for 15 days, so it was much easier. For us, the biggest challenge was maintaining that animal for 5 months. So
yes, you have all these air conditioner and keep them.
That research organization had.
It is very difficult. That's why I am asking this.
We lost one animal during anesthesia. So after 1.5 hour surgery, we lost that animal. One after post-operatively also. So that reduced our sample size a little bit. But it is definitely challenging.
Summer.
Ethical issues
because
whatever
of
the
this,
ARGO guidelines are there, we can't.
Because of this, I think I am now associated with the National Facility for Biotechnology in Calcutta.
So you have to collaborate with some very good those who have permission for a longer period of time. cannot do it newly, something in your mind, you can do, you approach, then usually it rejected. They know you cannot sacrifice the rabbit or whatever.
Yeah. But
Mainly the rabbit
there is a
model.
new, I forgot the name of the organization in France. They are doing something on cornea research without animals. Whatever you cannot do in animal because of these all restrictions. So this National Facility for Biotechnology in Khalsa College, that professor was explaining to me. Maybe I'll find out and give you the details.
Okay.
But I think animal research is becoming a big problem.
Big problem.
Because everywhere it's animal rights and...
Yes.
PETA. So we thank the chairman, the co-chairman, all the esteemed judges here for taking out your valuable time and being with us here. So the first session of the ARC has kick-started with thanks to all of you. And thank you to all the speakers also. It was an amazing session. And let's hope we see you in the finals also and we'll know. Yes. Can we have all the judges here, please? We can have a group.